Welcome to another lifelong nursing video. In this video, we focus on the multi-system concepts for the CCRN examination. Let's get started. So the multi-system CCRN testable areas include multi-organ dysfunction syndrome, distributive shock, multi-system trauma, sepsis and septic shock, inhalation and ingestion of toxic substances, asphyxia, toxin and drug exposures. So we'll first start with trauma. When you're answering trauma-related questions, you want to make sure you first know the first line assessments, and second, know the second line assessments. And we'll go over those in this video. This can be the difference between life and death. Thinking quickly and acting quickly are vitally important, but knowing what to do is just as important, if not more important. So the first line assessments of the trauma is A, B, C, D, E. A's airway. How stable is this patient's airway? Is it patent? Does this patient need intubation? Do you need to lift up on the patient's chin to provide breaths? B is breathing. How deep or shallow is the patient breathing? Is the patient breathing at all? During trauma emergencies, provide 100% oxygen and ventilation. C stands for circulation. What is the circulatory status? Is it severe bleeding? Pale-looking patient? Have you assessed the patient's blood pressure? Provide at least 2 large bore IVs with fluids opened. Provide at least 2 large bore IVs with fluids opened, typically isotonic fluids. Continuing with the first line assessment, D stands for disability. What is the patient's neurological status? Can they move their extremities? What extremities do not move? Perform a quick level of consciousness, motor, and pupil assessment. Remember that the Glasgow Coma Score is only part of the neuro exam and not all of the neuro exam. E stands for environmental and exposure. Where is the patient? Is the patient in water or snow, out in the hot weather? Think of their safety and provide warm or cool changes to the patient to the best of your ability, such as a blanket for the cold patient. Continuing on, after the first line assessment and interventions you perform on the patient, which are the most important, you should immediately move to the second line assessment. The second line assessment, which is more letters, F, G, H, I. In the second line assessment, F stands for full set of vitals, such as an ECG monitor, pulse oximeter, blood pressure, temperature, and if ordered, a urinary cath, radiologic studies, a gastric tube, intubation, and obtaining labs and things like that. G stands for give, so you want to give comfort measures, pain management, reassurance, hand-holding, etc. H stands for history. Try to obtain what happened, any recent medications, and last dose taken, any allergies, etc. I, inspect fully. Inspect every nook and cranny of the patient to the best of your ability. You want to remember to protect the patient's neck and airway and the spine if it has not been cleared by the doctor or nurse practitioner. While you're doing this, be sure to look at the back of the head and the entire posterior of the patient. You do not want to miss anything on a trauma patient. This will delay complete care. So now that we've got the basics of trauma, we're going to do a little introduction to shock. This will be primarily what you need to focus on in this video. Contrary to the belief that shock refers to the patient's hypotension and low blood pressure, shock actually means that the cells are becoming diseased due to 2 things. 1, a deficient in oxygen demand, which is not enough oxygen for the body, often due to inadequate perfusion, or the cells of the body are not able to utilize that oxygen they do have or do receive. There are 3 basic phases of shock. Now listen to this, phases of shock, not types of shock. So we'll get into the types of shock a little later. So the 3 basic phases of shock and how fast the patient progresses through these 3 phases depends on many things, such as how strong the body's response is to the shock. So the 3 phases include compensatory, which is the early phase of shock, 2, progressive, and 3, refractory. So this is the late stage of shock. So the first phase of shock, compensatory. While the compensatory phase of shock, which is the early stage, the body responds by activating the sympathetic nervous system and the renin-angiotensin-aldosterone system. The next 2 slides will show each respectively. So under the sympathetic nervous system activation, this is activated by a decrease in cardiac output or an increase in oxygenation. Once the sympathetic system is stimulated by above measures, vasoconstriction begins with the vessels of the body. This increases and maintains the blood pressure, which increases both the contractility of the heart and the heart rate. The renin-angiotensin-aldosterone system is also activated by the same measures of the sympathetic nervous response. So this is a decrease in cardiac output or an increase in oxygenation. So once activated, both responses are simultaneously ongoing. So on the top, we have the renin secretion, which converts to angiotensin 1, then converts to angiotensin 2, causing vasoconstriction. At the same time, aldosterone is being released, and sodium and water are being retained in the kidneys. The extra sodium and water increases the vascular volume, which helps maintain the blood pressure. So you have two mechanisms, vasoconstriction, and another, maintaining sodium and water, which will both help maintain blood pressure. This only continues for a certain amount of time, and if left untreated, the body will continue to deteriorate, being able to compensate less and less through these methods. So what are the signs and symptoms of the first shock phase? Restlessness, anxiety, tachycardia, tachypnea, which can lead to respiratory alkalosis, a normal PaO2, so on your blood gas, your normal oxygenation on your blood gas is going to be normal, oliguria, due to the hypotension, pale skin, again due to decreased cardiac output, and the patient may be more thirsty. Remember, in the first phase, there is no significant change in blood pressure related to the compensatory systems. So moving on, if the first stage of shock isn't treated early, we're going to move into the second phase of shock. This is the progressive phase, which is when the compensatory systems begin to start failing. So you're going to see worsening tachycardia, metabolic acidosis, a decreased PaO2 on your blood gas, cool, clammy, and mottled skin. This is where you're going to see a change of level of consciousness. May complain of nausea, and hypotension begins. This is also going to be the reason why you have a change in level of consciousness, and also for the acidosis. So the mechanisms that keep the blood pressure maintained is failing, which is the angiotensin-aldosterone system, and the sympathetic nervous system response. So these are going to be leading to a lower blood pressure. This is also called a sympathetic withdrawal. So in the third phase of shock, this is when the body does not respond to interventions that you are giving. The patient may survive the shock, but die from organ failure. You're going to have in this phase severe systemic hypoperfusion, which leads to multisystem organ dysfunction, otherwise known as MODS. Neurological signs, you're going to have encephalopathy, possibly a stroke. You're going to have heart failure and ischemia. For the lungs, you're going to have acute respiratory distress syndrome, ARDS. The liver can also begin to fail. Kidneys, you're going to have acute tubular necrosis and start going into anuria. Hematological signs are DIC, which is both the bleeding and clotting disorder. So now that we've been through the phases of shock, we're going to go through the specific types of shock. So each type of shock, hypovolemic, septic, anaphylactic, cardiogenic, neurogenic, obstructive, they're all going to have those three phases of shock: the compensatory, the progressive, and the refractory. So it's important for you to recognize the early stages of shock and begin treatment immediately so that you hopefully reduce the risk of leading the patient into refractory shock. So remember, specific types of shock, these are not the phases of shock, they're a specific reason why the patient is in shock. In other words, what has caused the shock to start? Is it hypovolemia? Is it due to sepsis, anaphylactic shock, cardiogenic, neurogenic, or obstructive? So obstructive can be a few things: cardiac tamponade, massive pulmonary embolism, which will cause right heart strain, and tension pneumothorax. So under the first type of shock, hypovolemic, this is defined by a reduction in circulating volume leading to impaired tissue perfusion. This can be defined by hemorrhagic or non-hemorrhagic. This is important to distinguish because your treatments are going to be different. So under hypovolemic shock, you can have hemorrhagic or non-hemorrhagic. Hypovolemic shock is the most common cause of shock, and there's two main causes. There can be internal causes, which is pooling of fluid in the intravascular compartments, third spacing, and the external causes, such as GI or renal losses, hemorrhage, burns, or excessive diaphoresis. So how do you evaluate hypovolemia? Hint, it's not just a low blood pressure. you're going to begin to see a narrow pulse pressure due to the systolic decreasing while the diastolic remains or elevates. This leads to a narrow pulse pressure. Example, your baseline blood pressure was 124/82. When you start to begin losing circulating volume, hypovolemia, you're going to have a narrowing pulse pressure. For example, the first one, 112/82, it's going to lead to 102/78, and after losing a lot more fluid, you're going to come down to like 88/68. So this is a narrowing of the pulse pressure. It's not just a low blood pressure. That narrowing of the pulse pressure is what will give you the hint that this is hypovolemia. So moving into the hemodynamic changes in hypovolemic shock. Remember, this can be hemorrhagic or non-hemorrhagic. So in hypovolemic shock, you're going to have an increase in systemic vascular resistance. This is going to be your blood vessels trying to go through that first phase, compensatory phase, where they're constricting and increasing the systemic vascular resistance to provide an increase in blood pressure. However, in this type of shock, hypovolemic, due to the decrease in circulating volume, this is not really going to help the blood pressure very much. So you're going to have a decrease in blood pressure, decrease in cardiac output and subsequent oxygen delivery, decrease in pulse pressure, and a decrease in right atrial pressure, which is also referred to as a central venous pressure, and a decrease in left atrial pressure, which is also referred to as the pulmonary artery occlusion pressure. Notice that everything decreases except SVR. So what are the treatments in hypovolemic shock? Again, you need to determine if it's hemorrhagic versus non-hemorrhagic. So you want to find the reason and attempt to correct it. That is your main goal, first of all. Secondly, you want to replace the lost volume as quickly as possible. Remember those large bore IVs and use a fluid warmer if you're going to give more than 2 liters of fluid in an hour. Use 0.9% saline or lactated ringers. There are several reasons to replace lost volume other than the blood pressure. You want to maintain the O2 delivery and uptake into the tissues. You're going to help sustain aerobic metabolism. This will help reduce the acidosis. Remember, if you stop the aerobic metabolism and go to anaerobic, you're going to build up lactic acid, which leads to metabolic acidosis. You also want to increase the kidney perfusion for increased urine output and decrease the patient's tachycardia. I cannot stress this enough. We all have a knee-jerk reaction to giving pressors after 1 liter of 2 of a fluid bolus. For the CCRN test, do not give pressors in hypovolemic shock. The systemic vascular resistance is already high. We do not want to further increase the SVR, making it harder for that heart to pump against that SVR. So when we think about stopping the rescue treatment and convert to maintenance treatment for hypovolemic shock, we're going to do this if the heart rate decreases to normal, if the CVP goes up to about 6 to 10, and this is kind of controversial, if the MAP is greater or equal to 65, if the urine output is at least 0.5 milliliters per kilogram per hour, that is the minimum amount of urine to be able to convert to maintenance. And if it is hemorrhagic shock, you want a hemoglobin greater than 7.0 and normalization of the platelets and coagulation profiles. This is because just the hemoglobin is not accurate during acute blood loss. Now we're going to focus on specifically the hemorrhagic type of hypovolemic shock. I want you to look at the hemorrhagic classes. There's 4 classes of hemorrhagic shock, and I'll post a link to the description box below this video, and I'll place it on lifelongnursing.com. So class 1, you give crystalloids, fluids. Class 2, you're only going to give crystalloids. Class 3, you're going to give crystalloids in blood, and you want to do the same thing for class 4. Class 1 is the least serious hemorrhagic shock, and class 4 is the most serious hemorrhagic shock. So again, please check out the cheat sheet linked in the YouTube description or on lifelongnursing.com. The specific treatment for hemorrhagic hypovolemic shock includes the following. You want to stop the bleeding if you are able to. You want to give blood transfusions. The most common accepted hemoglobin, again, is 7.0 to aim for in a trauma patient or any other patient before transfusing. However, the goal hemoglobin may be much higher in patients who are experiencing continued active bleeding and have severe hypoxemia, myocardial ischemia, and lactic acidosis. So we're not going to wait in those patients for the hemoglobin to get down to 7 before we transfuse. We're going to go ahead and transfuse those patients. In addition to the blood transfusions, you also want to give transfusions of fresh frozen plasma, platelets, cryoprecipitate, because the red blood cells do not contain plasma or platelets. Remember, we want that patient to resolve the hemoglobin and resolve the coagulation profiles. Sometimes the hemorrhagic shock is serious enough to start the massive transfusion protocol. This is a large quantity of blood that is brought to the bedside for rapid infusion to help restore oxygen delivery, oxygen utilization, and tissue perfusion. Indications for starting a massive transfusion protocol is traumatic injuries, liver transplant, ruptured abdominal aortic or thoracic aneurysms, or OB emergencies. The mortality rate in these patients are greater than 50%. You want to prevent the signs of near death, coagulopathy, which is DIC, acidosis, and hypothermia. So after the treatments, consider the risks of blood administration. Hypothermia, if you're transfusing a lot of blood, this can cause hypothermia. Blood is cold. So you want to give warm blood. Large amounts of cold blood leads to platelet dysfunction, increased affinity of hemoglobin to hold on to the O2, and impaired red cell deformity. You can end up with hemolytic and non-hemolytic reactions. You can end up with viral infections related to transmission through blood. Again, you can have coagulopathy, which you want to give platelets and plasma. And you can end up with hypocalcemia and hypomagnesemia. Moving on from hypovolemic and hemorrhagic shock, we're going to move into sepsis and septic shock. So this is the number one cause of death in the non-cardiac ICUs. Mortality rates in the United States are well over 200,000 deaths each year. And you want to know the difference between the stages of septic shock, not the phases of shock, but the stages of sepsis and septic shock. First, you have sepsis and septic shock. You have the systemic inflammatory response syndrome, SIRS. Then further progressing, you're going to move into sepsis, severe sepsis, septic shock, and then multiple organ dysfunction syndrome, MODS. So each step builds on each other. That, for example, 1 will lead to 2, 2 will lead to 3, 3 will lead to 4, and so on. For the first stage in response, for the systemic inflammatory response system, this is a system response with at least 2 or more of the following: heart rate greater than 90, a temp greater than 38 degrees Celsius, which is 100.5, or a temp that is less than 36 degrees Celsius or less than 96.8 Fahrenheit, a respiratory rate of 20 or greater, or a PaCO2 level of less than 32. This is going to be related to that respiratory alkalosis, that early phase of shock. White blood cell count greater than 12,000, or a white blood cell count less than 4,000, or just a shift in the bands to the left, which can signify an infection. It's important to note that a patient may have SIRS without sepsis related to a non-infectious injury such as burns or pancreatitis. That's why we call the systemic inflammatory response system the first stage before sepsis. So, moving on to sepsis. The criteria for sepsis is the same as SIRS: 2 or more factors, again listed there, plus a suspected infection or documented infection. You need positive blood cultures from blood, sputum, or urine. You want to be having a patient on antibiotics or other anti-infective therapy. You can have altered mental status, infected wounds, immunosuppression, pressure ulcers, urinary catheters, lung infiltrates on an x-ray, which could mean possible pneumonia. So you can have the 2 qualifiers for SIRS above, plus a suspected or documented infection, and that's what you can call sepsis. Remember, in sepsis, there's no organ dysfunction. So moving on from sepsis to severe sepsis, this is the presentation of severe sepsis, which includes all of those of sepsis, plus the signs of organ dysfunction. So you have the 2 signs of the systemic inflammatory response system, plus a suspected infection, and signs of organ dysfunction. So examples of organ dysfunction include an acute drop in urine output, acute hypoxemia, hypotension, mental status changes, lactate greater than 2.0. This is the anaerobic metabolism leading to lactic acid, which is showing you there is a decrease in oxygenation leading to less aerobic metabolism. Platelets below 100,000, or again, coagulopathy. There are signs of organ dysfunction in severe sepsis. In normal sepsis, there is no organ dysfunction. Moving on from severe sepsis to septic shock. This is the presentation of septic shock is all of those in severe sepsis plus one or both of the following: a MAP of less than 65 while giving adequate fluid resuscitation, or when adding a pressor drug such as norepinephrine to maintain the MAP of greater than 65 plus the fluids. Remember, there's a process that keeps building up and not just one single episode. So systemic inflammatory response goes to sepsis, to severe sepsis, and then to septic shock. So the last stage of septic shock and severe sepsis is multi-organ system dysfunction, MODS. So the progression from septic shock into worsening organ dysfunction. This comes in several degrees of severity, but in general, develops from the dysfunction of two or more organs, from slightly to severe, all the way to severe organ failure that is irreversible. This can continue to develop in two or more organs with the same degrees of dysfunction, that is ultimately leading to 80% of deaths in the ICU settings. Some of the signs of multiple organ dysfunction syndrome by organ system I have here. Neurologic, you can have delirium confusion and others. In cardiovascular, you can have tachycardia, dysrhythmias, decreased systemic vascular resistance, elevated troponin level. Pulmonary, you can have tachypnea, dyspnea, hypoxemia. Hepatic, you can have elevated liver function tests, hypoglycemia, jaundice. In the renal, you can have decreased GFR, oliguria, elevated creatinine. Metabolic, you can have, again, metabolic acidosis, elevated lactate due to the anaerobic metabolism. Hematologic changes include coagulopathy, thrombocytopenia, increased D-dimer levels. And under endocrine, you can have adrenal insufficiency and hypoglycemia or hyperglycemia. In sepsis or septic shock, you want to prevent MODS. This is the last stage. So since MODS has such a high mortality rate, especially in the ICU setting, we want to identify signs and symptoms prior to the patient developing MODS in order to treat the patient as early as possible. Remember, sepsis, severe sepsis, and septic shock is what you need to focus on in this video. First, let's see what you know. We're going to differentiate between sepsis, severe sepsis, and septic shock in a real-world example by the following. Number 1, the patient's blood pressure is 76/36. After receiving a 500 ml fluid bolus, the BP came to 100/56, so it was responsive to fluids. The ABG shows 7.31, an elevated lactate at 4.1, a base excess of -5, and the patient has an acute abdomen. So what's your answer for that? You can pause the video if you need more time. Number 2, the patient's blood pressure is 78/38. After receiving a 2,000 ml fluid bolus, the blood pressure came to 86/46. So even though there was giving more fluid, the blood pressure was less responsive. The ABG reveals pH of 7.31, an elevated lactate at 4.0, with the same base excess. So what do you think the answer is for that? Sepsis, severe sepsis, or septic shock? Again, if you need more time, pause the video. Number 3, the patient's blood pressure is 108/78. The ABG reveals a pH level of 7.33, a lactate of 2, a temperature of 38.9 degrees Celsius, which is 101.5, and a white blood cell count of 15,000. This patient also has an acute abdomen. So you think you have the signs of the elevated temperature, the elevated white cell count, fairly normal blood pressure, but an altered ABG. So what do you think that answer is? So number 1, severe sepsis. This is because of the beginning, the signs of organ dysfunction, such as the low blood pressure, the pH level, the lactate, and after receiving a fluid bolus, it was fairly responsive. Number 2, the patient's blood pressure is low. Again, after receiving a 2,000 milliliter fluid bolus, the BP was less responsive, and also you still have the altered pH and altered lactate. This is signs of septic shock. There's going to be a lot less response by the body because they're running into that compensatory withdrawal. Number 3 is sepsis. That's the easiest one. The patient's blood pressure is okay. There's no change in blood pressure in sepsis. This is the signs you need to watch out for before the patient gets into severe sepsis and septic shock. So you got a acidotic pH, but it's on the lower side. It's not as acidotic due to the lactate being a lot lower than 4. And you're going to have an elevated temperature and an elevated white count. So that's the first sign of SEERS. And then the second sign leading to sepsis is the lactate or pH. So how did you do? If you did well, great. But if you didn't do so well, you need to study. If you did great, study some more. It's very important for you to know sepsis, severe sepsis, and septic shock front to back, in and out, not only for the CCRN exam, but for the care of your patient. So let's go into depth about sepsis, severe sepsis, and septic shock. The pathophysiology of sepsis includes, again, sepsis, severe sepsis, and septic shock are the beginning and progressing identification of intravascular inflammation. So during this inflammation, activation of coagulation, cytokines, and subsequent kinin cascades begin to release many mediators to assist in the cause of the inflammation. For example, common causative organisms of this inflammation include gram-negative bacteria, gram-positive bacteria, fungi, viruses, and parasites. So notice I, just for fun, colored the gram-negative as pink. That is, in the real world, they stain pink. And then the gram-positive bacteria stain purple or violet. Some risk factors for sepsis include chronic health problems, surgical wounds, invasive procedures and devices, extreme spectrum of age, such as very young, very old, prolonged hospitalizations, alcoholism, history of a splenectomy, patient with HIV leading to AIDS, and malignant cancers. So some signs of septic shock include early signs, include fever, oliguria, tachycardia, bounding pulse, and so on. And then the late signs, you're always going to have fever and elevated white blood cell count, hypothermia, anuria, lethargy, coma, and the rest you see there. So essentially, the early signs are not as serious, the late signs are a lot more serious. Some of the hemodynamics of septic shock is early and late. The early signs are when the body is trying to compensate. So you're going to have an increased cardiac output, increase in cardiac index, the SvO2 is increased, oxygen delivery is increased, your right atrium, your pulmonary artery, and your pulmonary artery occlusion pressure is decreased, your SVR is decreased, and your O2 consumption is decreased. So late signs include cardiac outputs decreased, your SvO2 could be variable, O2 delivery is decreased, your pressures are increased, your SVR is variable, and then your O2 consumption is decreased. So in the early stages, your body is trying to compensate. So in the late stages, the compensation of your body is beginning to wear off. So let's look at the diagnostic results of septic shock under the early stage. Again, the compensatory stage. Your white blood cells are going to be increased or no change. Your glucose is going to be increased. Your lactate is going to be increased. Your troponin is going to be increased. Your PT, PTT levels are going to be increased. Your platelets are going to have no change or may be decreased. Your ABG is going to show respiratory alkalosis due to the tachypnea, mildly decreased PaO2, or you may have both respiratory and metabolic acidosis. So this is going to depend on the patient. More commonly, you're going to have respiratory alkalosis very early, and then later on in the early stage, you can end up with respiratory and metabolic acidosis. So, in the late stages of septic shock, your white blood cells are going to be decreased. Your glucose is going to be decreased. So this is some of the signs of organ dysfunction. Your body is not being able to produce the white blood cells as fast. Your glucose is going to be decreased because the infection may be using up that glucose, or your liver is not being able to keep up, or your adrenal glands are not being able to keep up as well. Your lactate's increased, your troponin is increased, your PTT and PT is significantly increased. Your platelets are decreased significantly, again, due to the compensatory stages being gone through and you're going into the refractory stage. And your ABG is going to show metabolic acidosis and significantly decreased PaO2. That is decreased consumption of the oxygen due to this acidosis, due to lactic acid, due to your body's inability to compensate any further. So treatment of sepsis, severe sepsis, and septic shock, you want to first draw 2 sets of blood cultures from different sites as soon as possible in order to start antibiotic therapy as soon as possible. Second, if the patient remains hypotensive despite fluid challenges, you want to begin norepinephrine. Levophed is the first line vasopressor. Second line is epinephrine. If the patient has cardiac dysfunction, inotropic therapy is recommended to support the heart, such as dobutamine, and also consider PRBC transfusions if the hemoglobin is less than 7.0. So remember, We want to do pressors here because our SVR is decreased and not like with hypovolemic shock when your SVR is increased. So your goals of treatment: you want warm extremities, you want normal mentation, normal heart rate, a decreased lactate, urine output above the minimum. You want a central venous pressure of 8 to 12. Again, this is a little bit controversial. And you want a MAP greater than 65. Wow. So that was a lot for shock. I hope you got all that. Please remember to refer back to the video and study the shock portions, the phases, the types of shocks. We went through the two most common. The other shocks, such as anaphylactic, obstructive, and all that, are less likely to be on the CCRN test. So we're going to move on to sedation in the critically ill. It is used to provide agitation and anxiety relief, and you want to use just a light level of sedation, which are associated with better outcomes in the ICU. The first line is pain medicine, due to pain having an adverse physiological and psychological effects such as a stress response, depression, and delirium in these patients. So the first line is pain medication. The second line is anxiolytics, anti-anxiety medication. Remember, sedation goal should be always known to the entire healthcare team, and you want it as light as possible. When using sedation, you want to use sedation vacations every 24 hours at least, which allows accurate neurological assessment and the patient to return to baseline neurologically. PRN sedation can be more effective at reducing the risk of oversedation rather than using continuous sedation. And you want to use the Richmond Agitation Sedation Scale, the RASS, to monitor the effectiveness of the sedation treatment, both before and after sedation. It may be different for your hospital, but for this CCRN test, you want to use the RASS screening. Frequent causes of agitation in the ICUs. Under environmental, you can have isolation, tubes and lines, noises, lights, temperature, restraints, and sensory overload. You can have emotional causes of agitation such as dementia, fear, anxiety, anger, and psychosis. Physiological signs include hypoxemia, hemodynamic instability, pain or withdrawal such as from alcohol or drugs, immobility, and sleep deprivation. Under pharmacological, you can have sedatives, analgesics, bronchodilators, steroids. It's that sort of thing that can cause more agitation. So the most frequently used sedative agents and on the CCRN exam is lorazepam, which your maintenance dosing is up to 10 milligrams an hour. Adverse effects include respiratory depression, hypotension, and renal failure. The second one is midazolam, which is Versed. Maintenance dosing is approximately 2 to 10 milligrams an hour. Adverse effects for that one is, again, respiratory depression and hypotension. You can also use propofol, which is maintenance dosing is 5 to 50 micrograms per kilogram per minute. And this is the one with more adverse events: respiratory depression, pancreatitis, hypotension, propofol infusion syndrome. It can lead to cardiac failure, rhabdomyolysis, metabolic acidosis, and kidney failure, which is often also fatal. These are the people that have been on propofol for a long time. Precedex, it's better than propofol and safer. You can use maintenance dosing of a max of 1.5 micrograms per kilogram per hour. Adverse events include bradycardia, hypotension, hypertension, and loss of reflexes. One thing to note about sedation is typically on the CCRN exam, you do not need to memorize dosing, but just the concept of the type of drug and its adverse reactions. You also need to know the reversal agents of benzodiazepines and opioids. So benzodiazepines, it's Romazicon, shorter half-life than benzos, so monitor for resedation. Opioids is one we're all really familiar with, Narcan. Again, it has a shorter half-life than opioids, so again, you want to monitor for resedation. So now that we've gone through sedation in the critically ill, we want to go through analgesia in the critically ill. Pain assessment and management is vital to the patient in the ICU areas. Common causes of pain in the intensive care areas include trauma, fractures, incisions, immobility, tubes, lines, invasive procedures, airway suctioning, dressing changes, and therapy such as PT and OT. In order to treat the pain, you need to have a pain assessment. You should always use a verbal score if the patient is able to verbalize their pain level on a 0 to 10 basis. Using other pain scales such as behavioral pain scale or the critical care pain observation scale should be used for the patients who are unable to verbalize their pain level, for example, the intubated and sedated patient. It is important to note that not only vital signs should be documented for pain assessment. So pain management. First, you should always try non-pharmacological interventions such as distraction or relaxation therapy. However, this isn't appropriate for trauma and surgical patients. The first line of choice for treating acute non-neuropathic pain in the ICU areas are IV opioid medications such as Dilaudid and morphine and fentanyl. Again, the reversal agent for opioid medication is Narcan. That's right. So frequently used pain medications in the ICU setting is fentanyl. The maintenance dosing is 25 to 200 micrograms per hour depending on weight. It's important to note that this drug is associated with less hypotension than morphine, and some of that adverse reaction again is hypotension, respiratory depression, and builds up with liver impairment. Another pain medication you can use is Dilaudid, 0.5 to 3 milligrams per hour, increasing the rate Q30 minutes by 25 to 30%. This is just for the CCRN exam. This is helpful if the patient is tolerant to morphine and fentanyl, meaning using fentanyl or morphine is not really helping their pain. Adverse effects of Dilaudid include hypotension, respiratory depression. It builds up with both renal and liver impairment. The last one you commonly use is morphine. It can be 2 to 30 milligrams per hour. Again, this is really going to depend on how tolerant the patient is. And adverse effects include hypotension, respiratory depression, and histamine release. You don't necessarily have to remember the dosing, just remember the type of medication, sedative or analgesic, and the adverse effects on the patient. So moving into toxic ingestion, this may be non-intentional or on purpose. Initial treatment for toxic ingestion is the ABCs, just like in the trauma. So the airway, breathing, and circulation. If the patient is comatose, we're going to give 50% dextrose, thiamine, and Narcan. This rules out hypoglycemia as the cause, Wernicke's encephalopathy as the cause, and overdose of opioids. Next, you want to give activated charcoal 1 gram per kilogram via a gastric lavage. Do not give with corrosive ingestions such as iron, lithium, or alcohol. Next, remove the drug if possible, again, gastric lavage, hemodialysis, or urine alkalinization. You want to monitor for urine output, and you want to monitor for any arrhythmias. Common causes of toxic ingestions are Tylenol overdose, benzodiazepine overdose, beta blockers, cocaine, alcohol, ethylene glycol, opioids, aspirin, and methamphetamines. Just so you can refer back, please see the toxic ingestion cheat sheet at lifelongnursing.com or the link in the YouTube description below in order to refer to the sheet instead of this video. And that's the same thing I want you to do for the hemorrhagic classes. Moving on to targeted temperature management. This is also known as therapeutic hyperthermia, and it may be still referred to as therapeutic hyperthermia, but it also may say targeted temperature management on the CCRN exam. This is used for reducing the risk of neurological deficits from injury to the brain or survivors of severe myocardial infarction or sudden cardiac death. The target temperature by American Heart Association and the CCRN exam is 32 to 35 degrees Celsius. However, there still remains some controversy, and therefore the target temperature may not be on the test. However, when ordered, determine if the patient meets the inclusion or exclusion criteria, which is located on the next slide. So the inclusion-exclusion criteria for therapeutic hyperthermia. First, you want to exclude the patient. This is patients with shock, pregnancy, hemodynamic instability, active bleeding, chronic renal failure, drug intoxications, ages less than 18 or greater than 85, and a current core temp of less than 35 degrees. Once you've ruled them out, you want to proceed with the inclusion criteria. If the patient was in cardiac arrest less than 60 minutes prior with return of spontaneous circulation, or if the patient is unresponsive or not following commands after cardiac arrest. So this is going to be when the patient is not at baseline after suffering a cardiac arrest. So targeted temperature management includes 3 phases: the induction phase, the maintenance phase, and the rewarming phase. The first phase include you want to start as soon as possible. Ideally, you should begin within 30 minutes of the cardiac arrest. However, research says you can start it up to 6 hours later. Maintenance phase includes 24 hours of therapeutic hypothermia, while you're maintaining and monitoring the patient's vital signs and blood pressure and labs. The rewarming phase includes slowly increasing the patient's temperature to at least 35.6 degrees Celsius. So during the induction phase, you want to monitor temperature by rectal or bladder probe. So this is going to be continuous temperature monitoring. And you want to have the patient deeply sedated and on a paralytic to provide comfort and reduce the shivering. You want to have baseline labs before you start, including the glucose and a 12-lead ECG. The BP goals during therapeutic hypothermia is having the systolic greater than 90 and a MAP greater than 70. You want to monitor the effects of hypothermia, which is electrolyte and fluid shifts, insulin resistance, skin breakdown, reduced cardiac output, which can be reduced up to 25% when the patient gets hypothermic, and alteration in coagulation, neutrophils, and macrophages. So remember, as the patient gets colder or, cold blood, you can have alteration in platelets and the coagulation. And then the second phase, you want to maintain the goal temp no less than 32 degrees Celsius. You want to have your vital signs hourly. You want to monitor the glucose, and you may need an insulin drip. As the patient gets cold, you want to monitor the glucose because there is an increase in insulin resistance. You want to do labs every 8 hours, which includes a CMP, CBC, coagulation profiles, magnesium, phosphorus, and arterial blood gases. If a paralytic is used, and it should be, you want to monitor the train of 4 every hour to monitor for over-paralyzation for a goal of 1 to 2 twitches an hour. Rewarming phase. Rewarm the patient at least to 36.5 degrees Celsius by using passive technique. Your goal is 1 degree Celsius per hour. So generally, the rewarming phase shouldn't take about 4 to 5 hours if you are doing this correctly. Rewarming the patient causes potassium rebound. If infusing potassium, stop 8 hours before rewarming. You want to discontinue the paralytics while rewarming, and you want to continue frequent neurological checks. When the patient is fully rewarmed, you need to obtain those same labs again. Thank you for watching, guys. Please remember to go download the cheat sheets for hemorrhagic shock classes and the common toxic ingestions for the presentations for easy review. If you haven't already, please visit lifelongnursing.com for more free content. Also, don't forget to subscribe so that you continue to get updated content from Lifelong Nursing. And remember, learn everything.